Hi, welcome to System Logic. I'm Jason Lee, and I'm joined today by Mr. Brian Newell, who is, of course, a key central figure in the physician compensation space today. Brian is the VP of Provider Compensation at Endeavor Health, and most importantly, is a board member at the AAPCP, where we're here live today in Nashville, Tennessee. Brian, thank you so much for joining us.
Thank you for having me. Very excited to be here.
Yeah, absolutely. So, Brian, tell us a little bit about the organization that you're with back home, and then also a little bit more about AAPCP.
Sure. So I work with Endeavor Health, which is the merger of 4 different health systems in the Chicagoland area and the Chicago suburbs. I've been in my role for about 2 years. Prior to that, I was with Ascension Healthcare for 7 years and Northwestern Medicine on their strategy team.
Right.
Began my career in consulting.
Okay.
So I initially got involved in the AAPCP. I had just taken a role around transactions with Ascension, but I had very little foundation or knowledge in that area. And the AAPCP kind of came together with a few of us talking to each other on LinkedIn that had similar titles, that there was just a gap in knowledge and training and onboarding.
Yeah.
So we kind of recognized we had shared frustrations of how this is kind of a forgotten and not emphasized at the time area of employment within the system.
Yeah.
Recognize how important it was and how others were likely experiencing the same knowledge gap. So through some networking conversations, a few of us formed what is now the AAPCP. We have 5 board members who were all there at the beginning.
Okay.
And it's been so much fun and so fulfilling to see the conference grow every year.
Yeah.
And the credential get launched.
Oh my
and
gosh,
expand
so
our
exciting.
offerings. So
Yeah.
this is my favorite week of the year, to see the same people over, to see new faces, and at the end of the day, we're all struggling with the same problems.
Absolutely. Absolutely. No, I was talking to some folks in the hall earlier today, and a little bit about how many new faces. Somebody was saying, golly, 35% or thereabouts of people that are registered this year are first-time attendees, which is fantastic. Speaks to the growth, the leadership that the board is providing, and you must be very excited about that year over year.
Yes, we're still very much in growth mode. At the same time, we don't want to get so big that we lose the kind of personal nature of the conference gathering. Kind of a balancing act, but a lot of it has been word of mouth and people telling their coworkers, come next year with me. So a lot of it has been kind of organic growth within organizations we may already have a relationship with that are starting to recognize the value and the investment coming here.
Yeah, and previous to AAPCP, I got to assume you at least did a few conferences, or were you parts of other organizations that are in the industry? And what are some of the pluses? What are some of the good things that you brought from some of those experiences to AAPCP?
Sure. So a lot of those, like the American College of Healthcare Executives or Beckers, have more generalist content, which is great. You can kind of get strategy and operations and finance through different sessions, but everything comp related was very cursory.
Yeah.
So there may be 1 or 2 electives throughout the whole conference that you kind of focus on and learn something. But we recognize there's kind of a gap in this niche industry that is really important to solve. So having these kind of deep discussions, having the networking, having the breakout sessions, we thought this really makes us unique. That you're not in a lecture hall with 400 people listening to Scottie Pippen or do a keynote address, which is really interesting, but it's not really relevant to what our day-to-day work is. So we really, our number one mission and goal as the association is education.
Yeah.
So we strive, all of our sessions are geared towards that. And I can honestly say, coming here every 5 years in a row, I've taken something away.
Yeah, and I want to talk to you more about that later from an education standpoint. But as you think about what we focus on, and I've been in the industry for 20 plus years, and you've been in the industry for 20 plus years, and as you think about the challenges that we face as an industry, right? Obviously, during the time that I've been in the industry, the introduction of so much technology, the introduction of so many changes in reimbursement, a lot of consolidation in the marketplace. I mean, as you mentioned, Endeavor, of course, is the result of some consolidation and some systems coming together to form hopefully a better, stronger entity. Talk a little bit about how you've certainly experienced that in your career and how you view that as either a challenge or a boon as we go forward with both medical group operations broadly and specifically physician compensation.
Yeah, it seems like every system in the country right now is dealing with some sort of integration. They've either broken up, they've either come together, they're either acquiring practices very quickly, they're changing some of their hiring strategy to do more APPs or not. But at the end of the day, our whole job is geared around data.
Yeah.
And I remember one of the first conferences in grad school I went to, the CEO of Cigna was speaking. He made a comment that really struck with me. He said, we live in a sea of data, but we're dying of thirst. So much time that we do is wasted on piecing together different data sets, and cleaning up spreadsheets, and trying, especially if you're on different EMRs in your organization or have different RVU reporting systems. There's just so much room for error.
Yeah.
And there's so much need for trust.
Yeah.
As people bring different systems together, there's such a whole unrecognized data element that is something that we worry about.
Yeah.
And we spend a lot of time on of how do we get this right? But it's a challenge, and I know new software systems or help is on the way, which
Sure.
we're all very much looking forward to. We could spend kind of less time in Excel, and more time on model design or change management part or the conversations with physicians that ultimately help them understand things better.
Right.
Kind of demonstrate our competency, which builds trust, which is really.
Yeah, I mean, it's a little bit of a modern day take on water everywhere, huh? Right. So, as I mentioned, you're a board member of AAPCP or AAPCP, and been a member as such for a number of years. Certainly, setting the foundation for the organization was probably the focus for the early part of the existence. I don't know how much longer you're going to be a board member, but as you look at over the next 2 to 3 to 4 years, what are some of the focus areas for the organization? What do you want to really continue to drive toward as the organization continues to grow and provide more clarity?
So the launch of the CPCV credential was like our number one priority the past 2 years.
And CPC in this case is?
Certified Provider Valuation.
Okay, got it.
So it's the foundation body of knowledge that is relevant for people in our industry. Up until now, there's you can get an MBA, there's valuation credentials. There wasn't anything really specific to provider compensation.
Okay.
And I think anyone here would attest to the learning curve in this job is very steep. You have to be solid analytically. You have to know the legal and compliance requirements. You have to know how to communicate to different audiences very succinctly. So it's a really well-rounded skill set you need to have that none of us going into any of these jobs has all of that.
Yeah.
But launching the CPCV really it streamlines onboarding. It gets people more familiar with our profession very quickly. It's the foundation of the legal and compliance requirements that are really important for what we do. So getting that off the ground was huge.
And how do folks that are early in their career earn this credential? What's the process?
So it's all remote, and there's I think 5 or 6 online modules. Each module has 4 or 5 different courses.
Okay.
And there's 3 exams. So
3 exams that they have to pass through.
Yes.
Okay.
I think we're now at our 11th graduate, but we have a couple hundred people that are actively going through it right now.
Oh wow, fantastic!
Yeah, it's
just launched this quarter. That's amazing.
Yeah, the committee that put together was done a thankless job of consolidating decades of content into the curriculum. We're really excited about that. So I think that as an organization was a huge undertaking, and we're really happy.
Okay.
I think we're going to start. We had a board meeting yesterday where we had a little bit of a strategic planning session of what is our vision for the future. And we are talking about launching a couple different institutes as an AAPCP to kind of round out the other parts of the competencies that we need to have around
Right.
Having a deep knowledge of strategy and operations,
Yep.
and building a team, and career development. So some of the softer skills that,
Okay.
that are super important.
Okay.
That, not everyone has coming into their role. So
Yeah.
I think to the extent we're able to provide value in that space.
Now, do you have to be a member of AAPCP to take that certification exam, and how much does that cost?
Yes, you do. I think we try to the extent possible make things affordable for our members. Thankfully, we have sponsors and supporters like you that help us subsidize that cost. I think it's $500. So it should not be a barrier.
Okay.
We're encouraging leaders of teams in my position to encourage their more junior to take it themselves, but
Sure.
to encourage their more junior team members to be an important part of their career and
Right.
skill development.
Right. Sit alongside the FACHP or other certifications that are germane to the medical group leadership and,
Exactly.
and the health system leadership. That's fantastic, and bringing that to the industry, as I think you said, is there's a huge need for that, and there's a vacuum for these types of skill sets. And I have had many colleagues approach me, and we've had conversations about how do these medical groups fill all these roles? Physician compensation is such a complex, challenging, arcane area that I couldn't even grab a rev cycle person from down the hall or somebody from the finance team just around the corner in the cube next to where I sit. They wouldn't even understand what's going on because of all the different pieces that go into physician compensation. Talk a little bit about some of the challenges that you've heard about from members and organizations that you work with about the complexity, about what goes into physician compensation.
Yes, I think if you were to talk to anyone here, there's general consensus that there's a talent gap.
Yeah.
And not enough bodies to do all the work that needs to be
Yeah.
done. Many of us have had analyst or manager positions, and there's not many qualified candidates.
That's right. That's right.
That leads us to hire great people, but they may not have the requisite skills to hit the ground running right. That's why the credentials. Longer term, we need to work kind of on the pipeline.
Yeah.
We're talking about how do we get more involved with graduate programs,
Yes.
MHA programs.
For sure.
I think everyone generally agrees healthcare is kind of a calling, and people go into healthcare for very specific reasons, often altruistic. No one wants to be a provider compensation professional when they grow up. So it's
Not too common on the list of sixth graders.
No. So I think it's something that a lot of us acknowledge that we kind of stumbled into on accident.
Yeah.
And fell in love with the role and the variety. It sounds super niche and specific, but
Yeah.
the different flavors of what you deal with every day and what physicians you're working with, what service lines, if you're focusing on the compliance or fair market value one day, you may be in front of a room of doctors explaining the model on another. So
Yeah.
no one has all of those skills coming into it.
Right.
Which makes recruitment challenging, but I think what we're doing as an association is filling that void. And we just need to figure out how to get more upstream with people more interested and aware and qualified.
Yeah, no, and I think starting the certification will start to initiate that chicken or the egg situation where you do have some folks that are in other parts of health systems, and they see there's a big need for provider compensation professionals, and there's like, hey, even though I work in accounting or finance or medical group operations now, if I can get that certification, then somebody like Brian that works at Endeavor or other places will see that on my CV, and they'll be much more likely to interview me and likely hire me into that role because I've got those skill sets.
Absolutely.
Right? Yeah, absolutely. So, as you think about the current environment that we have, provider shortages, provider access is a big issue. Both the incentives that we put in place to try to make sure that providers have as much incentive as possible to ensure access. What are some of the things that you see going on? What are some of the tools that you've found successful to try to improve access, to try to improve the physicians being more available to patients? Because at the end of the day, we're trying to take care of patients, we're trying to heal communities, we're trying to make sure that people can see both the primary care specialists and the specialties that they need to get better.
That's a really complicated question, and that's not always an easy conversation to have with physicians.
Yeah.
Experiencing burnout, spending way too much time pajamas closing charts that
Right.
to ask more of them is always a challenge. I think people view access differently and have different wants or needs. Someone younger with young kids, they may want a different appointment at a different time of day than someone who's retired and wants something early in the morning. So I think how you stratify that population and how you incentivize it can be a little different depending on specialty.
Yep.
You mentioned a provider shortage. That's something that keeps us all up at night. But how do we use advanced practice providers and nurse practitioners, assistants to kind of augment but not replace physicians in terms of access? And there's things you can do with an account model, like offering incentive revenue for offering a certain number of appointments after hours. It's very popular.
Right.
Work. How do you incentivize a care team that includes both a physician and an APP where they don't view each other as kind of competitive threats and cannibalize each other's volume?
Yeah.
There are ways that all boats can rise together. With team-based care models, we're very much in our infancy doing that, and mostly it's pilots at this point. No one has really solved that 100%. So it's something that we're all kind of striving towards is acknowledging there's going to be a huge problem in terms of shortage in 10 years. We need to start planning for that now. And the way we pay doctors today is not the solution for
Yeah. So it's pretty clear that providing a stronger, deeper pipeline of physician compensation professionals is a key focus area, a strategic goal of AAPCP. What's number 2 on the list? Are there other areas that you guys have spent some brain power and time thinking about as an organization?
Yeah, I mean, we want to reach everyone who would want to be involved. And that been making steady progress with that. We obviously haven't reached every organization, but there still are pockets of people doing things in a very decentralized way. Where part of comp may live in HR, part of it may be in finance, some of it may be in legal. That fragmented approach will not work.
Yeah.
So having centralized teams and with a dedicated leader who knows this in and out and is ultimately accountable for every cent on the physician's paycheck is really important. Because if you have the right department structure in place, if you have the right reporting structure, if you have the right data infrastructure, if you have the right guardrails for legal and compliance, it makes things so much easier.
So what do you say to that skeptical CEO, medical group CEO, or health system CEO that says, well, you can get half of Bob and half of Sally, and you can have one full-time person, and that should be enough? Like, what do you say to those skeptics that, that's either not enough, or how do you respond to some of those concerns?
It's a challenging conversation because it's not always top of mind. We're not always the first thing that health system CEOs want to invest in.
Yeah.
But I think a lot of it is, what are the consequences of not doing it right? And every year there's a couple Department of Justice and YG settlements in the 7 or 8 figures that we all study.
Right.
What did they do wrong, and how do we make sure we're not in the newspaper? And it's getting your leader to understand that our collective goal is to stay out of jumpsuits. Part of it is showing the consequences of what, if we don't take this seriously, what will happen. And one thing that's really hard to quantify is kind of the trust gap that physicians may experience if things aren't done well. And if they were paid incorrectly a decade ago, there's some scar tissue.
Still lingers for sure. So,
we're starting on strike 2 in that regard. That this can't be something that keeps them up at night. Their money has to be safe, and you have the right people structure to do that.
Yeah.
So now that the CPCV is launched, I think we're going to be spending more time on providing best practices and blueprints for building the right department. Make sure you have the right resources. What are benchmarks? When is it time to add an analyst? Are there common benchmarks we can use? Each analyst should administer to 250.
Yeah.
So I think you'll see us.
Rough staffing ratios, almost like a nursing ratio in a way.
Right.
Yeah.
And there's some great salary survey data from the big consulting firms that I think it's not our intent to replace that by any means. I think we can supplement some of department specific data elements because of kind of the network we've grown here to have a really deep understanding of how different teams.
Yeah, yeah. Well, as you think about the different ways you do things, you mentioned technology earlier and what some of the organizations that are present at AAPCP and certainly lots around the country. Um, the adoption of EHR has been now pervasive, and certainly the availability of data coming out of that is fairly decent now. I mean, it's way better than it was even 5 years ago. It's not 100%, but certainly way better. How are you encouraging organizations, and how are you doing that at your organization in terms of incorporating those pieces? What are some of the different ways that you're bringing in all the disparate pieces, whether it's quality data, productivity data, even physician satisfaction or patient satisfaction data for that matter, those sorts of things? How do you talk to us and tell the audience a little bit about how that gets done, how that sausage gets made, both where you're at and in organizations that you work with it through AAPCP?
So where I work, we're on 3 different EMRs right now. So
My goodness.
we're going to one later this year, which is a really important step that we'll have a common data foundation.
Yeah.
But we're not alone there. There's still a lot of people. Many health systems are doing things the old-fashioned way.
Yeah.
Joining export manner.
Yep.
You spend 80% of your time just on the data cleanup before you actually analyze the data.
Right.
So I think a lot of people are experiencing that right now. I mean, seeing where the technology seems to get better every year and some of the software that we've looked at, very promising. And now, 5 years ago, it was like, well, I wish it did this. And now it's like, I didn't know I even needed that, but it would solve a lot of frustration and problems. So we're all very excited with the support and progress that is going on in the software side of things, and being able to partner to reduce some of the headache on the grunt work that it takes to aggregate a lot of data.
Yeah, no, I think, like you said, the work that it takes to scrub that data and then ultimately provide that information to the physicians that are accessing it, to the leaders that are accessing it for analytical purposes. Are there any words of advice? A lot of the audience are newer medical group administrators and up-and-coming grad students that listen to this podcast. What advice do you have for them as they're thinking about approaching some of these challenges? Are there tips and tricks that you've learned over the years that can help make their growth easier?
Sure. I think how you say things matters as much as what you say.
Okay.
And I think a key skill that someone successful in this role is being able to speak many different languages, being able to synthesize things for our legal colleagues of why this arrangement is appropriate and necessary and not elevating any degree of risk is important.
Yep.
How you explain things to doctors who have had very little background or training in this. It's not something they cover in residency or medical school.
Of course not.
But trying to boil down concepts that I understand this now and it makes sense and I trust you. It's really important. How do you speak to your financial colleagues around forecasting their most expensive line item?
Right.
And, where we think things are headed in the next couple of years in terms of cost growth. So it's like I said earlier, it sounds like a really narrow field, but it's actually very broad.
Yeah.
And you kind of have to have different muscles depending on who you're speaking with. That it's really important to not have tunnel vision that all I do is run the numbers. It's a lot more than that.
Yeah. For sure. And we'll talk more about all that is in a moment. We'll be right back with Brian Newell. So we're back with Brian Newell here. Brian, when we took a break, we were talking a little bit about the AAPCP. I wanted to dive a bit more into your kind of thoughts and opinions about how medical groups and physicians are approaching compensation now. Certainly, you've been in the industry for a number of years. How has the incentive composition of those structures changed over time as you've seen it?
So I think a lot of it depends on what market you're in.
Okay.
So the way you pay your doctor is often a product of how you're paid by insurance. You're not incongruent with your revenue stream.
Of course.
You have to stay true to that. So being in the Midwest in Chicago, we're still very much a fee-for-service environment.
Yeah.
If I was out in Utah, in California within Kaiser market, that is a capitated environment with a very different reimbursement structure. It isn't really related to the more you do, the more you get reimbursed. So most health systems are probably more in the Chicago landscape right now in terms of still being very much fee for service. We've all been talking about this transition to value-based care for the last 20 years, but
Sure.
it's been slower progress than I think.
Is it ever going to happen, you think?
We'll see. I think the costs are getting so out of control that
Yeah.
we can't not do that.
Yeah.
And more and more people age into Medicare. There's going to be fewer and fewer on purely commercial insurance. So there's going to be some kind of a service mix paradigm that we're starting to see.
Yeah.
And I think more health systems are, we talked about a little bit earlier, there's a huge provider shortage. And we need to design both care models and compensation structure that aren't just totally driven by work RVUs.
Yeah.
I think there's still going to be a major component, and there's a lot of value in that.
Yeah.
But I think different health systems are looking more, especially as Medicare starts rolling out these mandates of passing risk on to health systems on the provider side. We can't ignore that. And some of the academics may focus more on episodic care and do the really complex cases.
Right.
But I think by and large, many are going to start actually paying attention to population health management and cost of care and making sure that a lot of the incentives that come into our inbound reimbursement, some of the third-party payer incentives, those need to be baked into every compensation.
Are you getting some interesting, reimbursement mechanisms? Your managed care team comes to you and says, "Hey, Brian, we negotiated with Blue Cross Blue Shield of whatever, pick a state, and they said we've got this new incentive piece." Are you seeing some different innovative things out there the last couple of years, or have we hit peak variety, if you will, of different models that health plans are trying?
It depends on what market you're in. So Medicare introduced the team-based care.
Right.
We're in the process of implementing that. That's not happening in my market, but we
Okay.
know it's coming.
Yeah.
Where you're going to get paid a fixed sum for patient based on their diagnosis or need,
Right.
regardless of how much you spend. So it is coming in fragments that you're not doing that overnight. It's just, this year it's knee replacements. Next year it's going to be low back pain. And they're focusing on their most expensive conditions that have the most variability. So, the first step of that is good evidence-based medicine. The second step of that is making sure there's not a financial disincentive for providers.
So maybe part of the key is to have a flexible component of your compensation structure that can adjust and be a chameleon vis-a-vis whatever incentives you're getting from those health plans.
Absolutely. So, someone in our position should be very closely aligned with our payer contracting colleagues that, what is on the horizon, that, what is our highest cost condition that we have the most financial risk on, and how do we align our comp model?
A little periscope out there to see in the next year or two, what is Blue Cross Blue Shield going to be calling about in the next couple of cycles? Yeah,
and it is a long planning and implementation cycle. A lot of us have plans where there's at-risk metrics that may change every year.
Yeah.
But getting into more population health management and having a primary care with a dedicated panel, these are all things that we're starting to think more and more about. That how do we still live in today's fee-for-service environment while acknowledging tomorrow is coming quickly.
Yeah.
And not just physician compensation. It's how do we get our APPs with aligned incentives.
Yeah, absolutely.
Very challenging concept, but a kind of a mission critical.
Yeah. One of the things that I have been thinking about asking you is, as you look at these systems that are coming together, and you must have had, call it a couple hundred docs over here and a couple hundred docs over here and maybe, 500 docs over here. Bringing all that together, were there bigger challenges in your mind related to the structure differences? Were there bigger challenges related to the cultural differences of access and that sort of thing? Or were there bigger differences related just purely to like total cash compensation is way different here than it is over there? And so that no matter how it got aggregated and put together, that's just going to be the biggest clash, and that's the biggest issue. What did you experience, and how did you overcome some of those friction points?
It's a great question, and I've worked with organizations where there was a larger, more successful system who had acquired a more of a safety net
Sure.
facility. Their doctors were paid very differently, mainly just for
Mm-hmm.
reasons. Like they couldn't afford to pay market.
Yeah.
And the other system absorbed that. It was part of their community plan and part of their commitment to communities where they serve. But
Yeah.
that's a very different integration than two halves coming together where they may be paid very differently.
Yeah.
And it's hard to even start the conversation that things may need to change. We need to do things consistently. It's not equal to pay differently for the same type of work. Just depending on where they're coming from, it's culturally that's very challenging.
Yeah. I mean, like you said, it'd be one thing if their rough total comp was about the same at the midpoint or the median, but one was way more quality based and one was more RVU based, let's say. That is a challenge that I think you have to overcome, but it's way easier than if the disparity, even if the structure was identical, but the pay amounts, total cash was way different. That's a much bigger challenge in my mind.
Yeah, and being able to demonstrate that is very important. Showing them the data, hey, here's where you are now, here's how you would do on this new plan. It won't get off the ground without that. There will not be any buy-in that you're talking in abstract concepts without hard numbers that how this impacts me specifically now.
Yeah.
It's a fatal mistake to communicate concepts without the data very shortly.
Yeah, and we've been talking a lot about the importance of data transparency, and then the challenges of change management. As you fold in the question of technology, right? I often ask a lot of guests and a lot of folks that I meet at conferences like this one, how do you see the availability of data and the deployment of technology over the next 12, 24 months impacting what you do? And, I would pose the same question as we think about a lot of these medical group leaders and these physician compensation leaders out there, they're having to do the things that you're talking about from a change management perspective. How are they using technology? How is that making their job easier, harder, more headache-filled, less headache-filled? What do you say?
So I think step number one, and what we spend a lot of time and energy is just getting physicians their simple data on them.
Yeah.
It's harder than it should. So if you're spending multiple FTEs basic monthly, that means you're probably not going to be reaching higher level.
Yeah.
So some of the technology solutions, just simplifying that part and giving physicians, which sounds like should be table stakes, but isn't,
Right.
better than it sounds,
Right.
accurate monthly data, say, here's where you're at. Here's where you're trending towards from a financial perspective. Here's where you may need to course correct if things are off kilter, legacy relative to legacy patterns, or here's how your coding may have changed. Here's how it compares to your partners in your practice. All of that is data that they're entitled to, but may not get on a daily or monthly basis.
Yeah.
So that type of lack of data and transparency kind of breeds mistrust in the overall comp. What are they hiding from me?
Right. Sure.
Why don't I have
Yeah.
this? Why don't
Not
I
even an error, just a lack of information
Right.
is, yeah.
And I think it's underestimated how, with all the different data systems, health system,
Yeah.
I think people take for granted how much more difficult it is than it should be.
Yeah. Yeah. No, that's fair. That's fair. And of course, the big specter over the last year or two is AI and how AI has changed technology and been integrated into technology. What are you seeing at your home organization, Endeavor, and also amongst the organizations that you talk with? How are they using AI, and how are they anticipating AI might impact their day-to-day here going forward?
So many systems are first focusing on, everyone acknowledges physician burnout is a big problem.
Yeah.
So a lot of systems are first moving in the ambient AI dictation systems. So
Sure.
They're able to have a face-to-face visit with the patient and not have to focus on being on the computer screen time.
Right.
Their chart is ready to go at the end of the visit, and that means they're able to close that in real time and not spend pajama time away from their family
Right.
at night, or not as much.
Right.
So I think that's going to be a big investment that continues to grow. And I know some of the software solutions are starting to offer that. Really important. The next, a lot of systems are focusing in AI in their revenue encoding, revenue cycle encoding, where AI platform that sits above their revenue cycle platform that makes sure that there's accurate charge capture, things were coded appropriately up or down, and making sure that the provider and the health system's getting all the credit that they're entitled to, which a lot of people were doing that out of necessity just because of how constrained costs are and shrinking markets. So those are the big two kind of first movers. A lot of systems or platforms are doing a lot of cool things in analytics that I may have to sort and filter and conditionally format a big spreadsheet to say who in this provider roster is above the 75th percentile. That takes a lot of time or energy, but some of the AI platforms I've seen do that for you. Ask a question
Instantaneously. It's pretty amazing.
Very much looking forward to that being our daily work. That would save a lot of time and effort.
Have you personally adopted some AI practices? Do you use any of the tools, or are you even allowed to at work, some of the tools to help you make your job day-to-day easier?
Not yet. I mean, if I have a really complicated question, I may check with ChatGPT every once in a while.
Sure.
But we're not on a daily basis, and we're not. We have some other work to do before we start relying on that. Being on 3 EMRs, I don't even think it's possible.
Sure.
It's something that we're all looking for.
Yeah, no, I can understand that. I personally have been able to adopt it in a lot of ways in terms of helping improve some of the documents that I produce, and certainly helping to edit something like the podcast. AI is very useful for that.
Awesome.
So hopefully you can pull in some of those pieces going forward. Well, just a couple of other questions here as we think about both the organization going forward, new professionals coming into the industry. How does an organization like this continue to stay front and center with those folks? And then what is something that you think, if they weren't able to make it to the conference this week, that you'd love for them to think about and take away from and maybe dig more into?
So I mean, we kind of have 3 segments within the AAPCP. There's the in-house compensation professionals who do this day to day. Who are really the beneficiaries of the other 2. That being the consulting firms that provide a lot of the content and webinars and expert guidance. A lot of times, one of the principals that I work with every day presented today. It was cool to be in the same room outside of work, and the value and support that they're able to provide the AAPCP, we couldn't do it. And the third is the technology, because that kind of harmonizes workflows. It helps with analytics. It just makes all of our jobs easier. And it's been exciting to see how much more sophisticated technology gets. So those are still our 3 prime focus areas. If you are joining the AAPCP, you're going to have exposure to all 3 of those. I think you make a lot of connections at the in-person conferences that will serve you well for many weeks or months or years afterwards. If you have a challenging question, you may remember a presentation from 2 years ago where they covered that very topic, and you don't want to reinvent the wheel.
Yeah, no, that's fair. So definitely some webinar content out there and some articles that some of the consulting firms have pushed out. It's a great way to pick up some of that content. And I'm sure there are many, many conversations at the conference that you are continuing to have. What else are you looking forward to in the next few days here at the conference?
Just the networking. Just catching up with people that you only see once a year. And watching their careers take off is really cool, as people may grow within their organization, and they may take a leap to a new one to have a new experience or an elevated role where they were kind of constrained at their current level and found a new opportunity, and it's been great for them. And having different teams interact with each other and seeing people trade sides, and it's really exciting just to see people's careers taking off. And the connections that people are able to make here that we'd like to think wouldn't have otherwise happened.
Yeah.
So that's the best part of it.
Well, and hopefully accelerating their career by achieving the CPV.
That's a great
A,
plug.
right? Yeah, yeah. Right. And where can folks go? Just to remind them, what part of the website can they go to learn more about the certification?
Oh, it's front and center of our webpage. We have an
is.
AAPCP webpage.
Okay, and that's at aapcp.com.
.com.
Okay, so go to aapcp.com. There'll be some links there if you want to learn a little bit more about the certification, how long it takes, what it takes, costs, and that sort of thing. You can go there to learn a little bit more about that. Advance your career, push forward a little bit in the medical group leadership, and join us in the island of physician compensation toys, as it were.
Yes, absolutely.
Well, any last things that you think that you would want to share with folks that haven't been able to come to the conference this week?
I would say there's not another event like this. And if you're in this industry, I think you'd be hard-pressed to find the level of education or content or connection anywhere else. I know I'm probably biased making that remark, but it's something that we take a lot of pride in and try to do things a little better every year.
Yeah.
So we're super excited about the future. This is our largest conference. I think we had 375 last year. We're at 440 this year.
Holy smokes.
We were at 100 our first year in
Yeah.
the middle of COVID in a basement hotel in Indianapolis. So we've come a long way.
Yeah.
We've grown together. We're very grateful for people who come back every year and the new faces and the support that the technology space has provided to our growth and not be able.
Yeah, absolutely, absolutely. Happy to do it. And certainly there's audience members out there that have been thinking about doing something like coming to AAPCP, and certainly we encourage them to do so. They'll learn a lot. They'll meet some great people, and potentially have a conversation like today's. So,
Absolutely.
yeah.
Thank you for having me.
yeah, Brian, thank you so much for joining us. And I know you got a lot more people to talk with, so we'll let you go. But appreciate your time today.
Thank you.
Thank you. So that's our episode of System Logic today with our guest Brian Newell, board member at AAPCP here live in Nashville. If you want to hear more conversations like the one we had today, please like and subscribe. Join us on YouTube, Apple, and Spotify. Until the next episode of System Logic, we'll see you next time.